Seclusion and long-term segregation are restrictive interventions, and for that reason using them should always be a last resort. However, there are times, for safety reasons, that it is necessary for a clinical team to use seclusion and long-term segregation. During these times we must be mindful that these interventions are a deprivation and therefore can be distressing for all involved. This is a short introductory video to explain the differences in seclusion and long-term segregation to aid understanding and ensure the appropriate use of each intervention. It is because of similarities in the use of seclusion and long-term segregation that it can become confusing about which intervention is the most appropriate to use. Both interventions can occur in an inpatient setting, but they can occur on any area of the ward. Both interventions involve preventing a patient from mixing freely with other people who use the service, and both interventions restrict the patient from leaving the designated area. It is up to the clinical team to make the decision about whether to use seclusion or long-term segregation. Once the decision has been made, it is important to follow the policy and procedures guidance to ensure the correct process is followed and all safeguards are in place. This includes using the correct terminology, forms, reviews and observations. A datix must be completed for the episode. A patient returns from leave and staff suspect that they are bringing illicit drugs onto the unit. When challenged, the patient became angry, verbally aggressive and attacked staff physically. Seclusion would be the correct intervention to use in this situation. The clinical team is likely to make a decision to use seclusion when it is immediately necessary, when the patient exhibits severely disturbed behaviour that is likely to cause harm to themselves or others, and when the event is unplanned. Once secluded, the patient will be under continuous observations which will be recorded every 15 minutes. Later on that day, the same patient assaults 2 members of staff, causing serious injury. When the patient was reviewed, it was noted that the patient continues to try and assault staff and medication is not helping to calm the patient down. Seclusion would be the correct intervention to use in this situation. The same patient was reviewed a day later, and since the last incident there have been no further assaults. However, there was still verbal aggression. Long-term segregation will be the correct intervention to use in this situation. The clinical team is likely to make a decision to use long-term segregation when patients would benefit from a period of intense care and support that minimises their contact with others, when there are continued risks of serious harm to others, and when the intervention is usually planned. Once placed in long-term segregation, the person will be observed continuously and this will be recorded hourly. It is critical to use the correct terminology for the intervention agreed. It is also important not to interchange terminology or processes. Therefore, when seclusion is used, all the records should reflect the seclusion process. It is important to learn from incidents. A debrief must be undertaken for patients and staff after each incident of seclusion and long-term segregation. This is to identify learning or good practice examples for the team. Learning should be cascaded to the rest of the team and across the organisation. Hopefully this video has helped answer some questions about when it is appropriate to use seclusion and when it is appropriate to use long-term segregation. If you would like to know more about these restrictive interventions, we have left some useful links and resources on the screen.